Okay, welcome and thank you everyone for joining us today for this special live broadcast. My name is Neha Prakash. I'm a 2013 graduate from the Gujarat Business School, and I lead the Emory India Alumni Network in Delhi. This presentation is part of our ongoing digital learning program sponsored by the Office of Alumni Engagement. As you all know, our world is becoming increasingly digital, so we are focusing efforts on bringing lifelong learning to a variety of digital platforms to meet the needs of our alumni, parents, leaders, and donors. Before we begin, two pieces of housekeeping to note. This presentation is being recorded and will be sent later today to everyone who is registered. Second, please type your questions in the question section of the platform, and we will get to as many of the questions possible during the presentation. So today, please join me in welcoming our presenters and our moderator. We're pleased to bring you the first presentation in our series titled A Virus Without Borders, COVID-19 and Its Lessons for the Global World. Our Emory faculty, Dr. Venkat and Dr. Amita, with our Rollins alumnus, Dr. Vivek, will share their area of expertise on COVID-19 epidemiology, surveillance, and response, taking the case of India and the US. So please join me in welcoming our presenters who will introduce themselves shortly, and our moderator, Nikhil Singla, the Country Director of Emory India Research.
Thank you so much, Neha, for the kind introduction. And thanks to the team, Katie, Chris, Michelle, Lane, for putting this together. Good morning and good evening to everyone on both sides of the ocean. We're really excited to get started with this series of webinar that we have put together to cover different aspects of this COVID-19 pandemic. The idea here is, there has been an informational news overload, and we wanted to engage with experts in terms of our faculty and alumni from Emory to provide us, critical and very useful aspects on different parts of this epidemic. Today we will be covering one part of it, focused on the public health side of it. And before we get to our panelists, I just wanted to quickly give a note on a new entity that Emory has formulated in India. This is called the Emory India Research and Education Innovation LLP. This is Emory's official and formal presence in India. The idea here is, we all know that Indian students form a big part of the cohort of students at the Emory campuses in Atlanta. We have a number of alumni across India with alumni chapters across major cities in the country. Various faculty members have a lot of engagements happening in critical areas in the country. Dr. Venkat Narayan, who's the panelist today, he is working on a lot of different chronic disease areas, including diabetes, cardiovascular diseases. We have our Emory Vaccine Center faculty who are engaged with the Premier Institute here in Delhi, working on infectious diseases, primarily emerging and re-emerging infections like dengue, chikungunya, and also the COVID-19 pandemic. We have, faculty members from across disciplines who are engaged in India. One of the faculty members, Professor Jack Shett, who has also been awarded the Padma Award recently, has been working from a business school perspective with various institutes in the country. So the idea of this new entity that Emory has formulated in India is to give Emory a formal face in the country, to expand and strengthen Emory's footprint in the country, to be the face in the country which enables engagement with local stakeholders, current and the ones we want to engage with moving in the future, and enable this communication and cross-learning, cross-exchange through the immense strength that we have at Emory, and leverage on that to further our collaboration with India and the partners here. So with that, I would like to start our session today. I am Nikhil Singla. Just very quickly, I'm heading the Emory India entity that I just explained to you about. We have 3 expert panelists with us. I would request each one of them to give a quick overview on their background, their work, and if they have any quick opening thoughts on the COVID-19 pandemic before we get into the specific questions, that would be great. So Venkat, can we start with you, please?
Yeah, thank you, Nikhil, and thank you, Lane and Katie, for putting this sadhana together, and thank you, Neha, for coordinating it. I am Venkat Narayan. I'm in the faculty at the School of Public Health and the School of Medicine at Emory University, and I run the Emory Global Diabetes Research Center. We have a very long history of very solid collaboration with India. A lot of our research is based in India through multiple funding mechanisms and over the last several years. And I'm really excited that India is one of Emory's 5 strategic countries when it comes to collaboration.
Thank you, Venkat. Amita?
Yeah, good morning, everybody. My name is Sunita Gupta. I am on faculty in School of Medicine at Emory, as well as in the Rollins School of Public Health. And, a lot of my work focuses on people living with HIV. I'm an infectious disease physician by training. And so that's a lot of my clinical work and program work. And India has largely focused on gender-based violence and developing culturally tailored strategies to measure violence as well as prevent violence in low-income communities. So thank you for having me.
Thank you, Amita. Vivek, please.
Yeah. Good morning, good evening, good afternoon to everyone, wherever you are, and hope you're keeping safe. So I graduated from the public health school, the Rollins, in 2008 from Emory, and I was also a recipient of a fellowship from Emory and the university's mandate to promote science across the globe. And currently I work with the UNICEF India country team. I'm leading the COVID-19 response with my chief of health, and very happy to be here.
Thank you so much, Vivek. Thank you so much to the three of you for joining us and making time with all that is going on with this pandemic. As the title of our series is A Virus Without Borders, we are really excited to have you on board because you all are in some sense providing expertise and presence across borders with the work that you have done in the US and in India, and of course with this technology working and getting information across borders. So I would like to start with you, Venkat, with your extensive experience of working in the public health space, both from an India and a US perspective, your experience of having spent time at the CDC, and a global perspective that you bring through your research. I would like to understand, what is the comparative assessment from an epidemiology perspective and a response perspective to the COVID-19 pandemic from India and the US, with one part. And from that assessment, what is your understanding of critical opportunities and cross-learning that both these countries can embark on in terms of collaboration and helping to address this global problem?
Thank you, Nikhil. That's a tough opening question, but I'll try to address it as much as I can. And firstly, this coronavirus, COVID-19, is a brand new virus to humanity. And what it has taught us all is humility and the importance of good science to understand it. We have learned as we have gone along that the virus is a lot more infectious than originally believed. I mean, its infectivity starts from less than 2 days, before symptoms, can go on till 14, 15 days or longer. The routes of infection can be droplets, can be fomites, and its R0 could be as high as 5, meaning one infected person can infect 5 others. So in that sense, it's a considerably more infectious than the common flu, if you like. And the second thing we have learned is that its mortality rate or its case fatality rate is a lot higher than flu. It's about, it's difficult to know exactly what the mortality rate is, but it's considerably higher than flu. So in terms of its potential impact, it can cause 20 times more deaths than a flu can do. I think that's important to remember, and it's a highly infectious virus. This is something that we have learned both in the US and in India and in other countries, and this is where importance of international collaboration is so critical. Secondly, we are also learning that the disease is asymptomatic. in very large numbers of people. I mean, it could be 90% or over can be asymptomatic, but they can transmit the infection. So we need to be careful in terms of just going by detected cases, because the asymptomatic ones can be in the community transmitting the infection. And thirdly, we are beginning to realize that the seriousness of the illness and death rates are much, much higher in people with existing comorbidities, such as diabetes, obesity, hypertension, chronic obstructive pulmonary disease, other immunosuppressed conditions, and also with age. Age is another factor that seems to be important. But I would like to extend the idea of comorbidities, not just about comorbidities in individuals, but also comorbidities in communities. We are noticing both in the US and in India that communities that are vulnerable are those with a higher proportion of poorer people, people without health infrastructure. Like in the US, we see a disproportionate number of African Americans suffering serious illness and death. So I think in that sense, we're beginning to understand a lot about the disease itself, who's vulnerable, which communities are vulnerable. So that's lessons. I think there are lots of similarities between the US, India, or for that matter, anywhere in the world. Now, coming to the response, we have to acknowledge that both countries, US and India, are large, diverse democracies, very large countries. So it's difficult to make general statements about response overall. I think what will be useful is try to identify some excellent examples in each of the countries. Like in India, I have been very impressed with the response from the state of Kerala. I think, and when we look at Kerala carefully, and whereas in the US, there has been a great example, such as the state of Washington. What is clear is in Kerala, they started very early. They acknowledged the potential seriousness of the disease very early. And it was led very much by science and data right from the beginning. They implemented identification and aggressive contact tracing and quarantine very early in the course of the disease. They also prepared very carefully all of the infrastructural needs, such as public health and primary and healthcare needs for hospitalization, etc., and attended considerably to the non-health areas too, such as movement of people, supporting vulnerable people in the community, the people who had to travel, etc. So all of that was taken care of. So, and then the financial hardships were also addressed. So I think all of that was addressed. And we had similar kind of experience in the state of Washington, where a lot of the response was led by science and scientific expertise, and control of the epidemic was able to be achieved. The other thing in the response is also the tone of the leadership across the country, and I've been very impressed that in India, the leadership has been pretty much giving out very consistent messages right from the top, and they started very early. In the US, we have had problems with consistent messaging. I think that's a place we can learn from each other. So, and I have other things that I can tell you later on, but in terms of where we can learn from each other, clearly one area where we can definitely go forward is science collaboration. Because whether we like it or not, understanding a new virus requires global collaboration, much faster, much quicker. Coming up with better vaccines, or good vaccines, is going to require global collaboration. And also evaluation of drugs for prevention or treatment should be based on solid evidence, such as randomized controlled trials. We have the unfortunate example of putting a lot of emphasis on hydroxychloroquine, for example, and we are realizing from data that may not be as ineffective or could even be deleterious for serious people. And similarly, there were stories about whether BCG vaccine might protect people. Again, data so far does not support it, and we have to wait for randomized controlled trials. So I would underpin the role of science and of global collaboration in science in an aggressive way, and the role of technology. How do you track and trace, contact trace? How do you deliver messages? All of that gets very important. So I think that's where I would emphasize. I mean, how can we collaborate better to strengthen surveillance systems? How can we collaborate better to strengthen science? And for sharing of information, I think one important, if there's one lesson from a pandemic, is that we have to know the truth, whether it is India, whether it's US, but anywhere in the world, because ultimately, that's what drives it. The sooner we acknowledge the truth, the better, the greater chance we have of managing the epidemic. So data, science is what I would underline. Thank you again.
Please, thank you so much for that, Venkat, and we couldn't agree more. And I think you, with your engagements on different with different experts in the country on different programs, and precisely the Emory India entity that has been established, has that context of facilitating the sharing of information, leveraging, the complementary and synergistic strengths that researchers on both sides bring to address problems like the one we are facing with this COVID-19 perspective. So also to the point of talking about how different states and regions have established different levels of response. The learnings that we can have from previous such experiences, like Kerala with its Nipah virus experience that has helped it in addressing the COVID-19 pandemic as well. On that note, I would like to move to Amita. Amita, you said about your extensive experience in the HIV field, especially from a social sciences perspective. HIV was one pandemic that there were suggestions that it will overshadow the public health system of India. And India has done well in controlling the HIV pandemic, and it has been a very significant program which has proven to the world, the positive attributions of controlling a disease like that. So what from your context would be lessons that we can learn, experiences that we can leverage on that can help us in addressing this COVID-19 pandemic and the situation, a similar situation that it is presenting in terms of breaking and overshadowing the public health systems that we have in the country?
Yeah, thank you, Nikhil. I think that's a great question. I think first and foremost, the largest learning from HIV as well as other epidemics is the need for community engagement. And, I think part of this gets to Venkat's point about the diversity of the epidemic across different communities and, recognizing that not a one-size-fits-all model will actually work. And so, really using community-based participatory methods to understand what are the barriers, what are the resources in various communities, and how, population needs differ across various communities. And so while it's really important to have an orchestrated, central government, state government response, there's also really a need to have this understanding and a continuous understanding of community needs in shaping our response to the epidemic. Second, I think, what we recognized with HIV as well as other epidemics, including gender-based violence, is that the vulnerable communities get hit hardest, and that they're also the ones that get, that we reach last. And I think we can learn a lot from prior epidemics and thinking about, what are the disparities early on, thinking about disparities across all levels of the system, whether it's prevention, whether it's adequacy of messaging, whether it's treatment, whether it's testing, really thinking about those disparities from the get-go and addressing each of those as we, early on rather than months later. Third is, kind of gets to Venkat's earlier point about the need for really clear, consistent, evidence-based messaging, and making sure that that messaging gets to all levels, everybody within society. And, given the rapidly evolving evidence-based, in the initial days of this epidemic was hourly, not even daily, but hourly changes in the scientific evidence base, was how do we communicate that in real time and get that from everyone to the state level and the policymakers, scientists, down to the community health workers, the ASHA workers who are actually doing the work out in the community. And so I think, ensuring that messaging is clear, as well as, to the public, I think will be really important. And then to ensure that there are bi-directional communication streams where the ASHA workers, the people who are doing the work on the ground, the clinicians on the ground, have a means of communicating to higher leadership, what is the continuous changing, evolving needs of the communities. Then, we talked about testing, and, availability of testing is really paramount. But along with testing, the understanding of what are the limitations of testing, what are the limitations of the test at present, and what is the functionality of a test needs to be understood not only by the scientists and the clinical community, but also lay people, because it very much shapes their own risk perception going forward and their risk behaviors. And then, perhaps lastly is the need for, thinking about stigma. And I think what we can learn a lot from HIV and other pandemics is that what happens often is that these epidemics tend to make us see fault or an inherent flaw in a person. Rather, it's not the person, it's often the system or the resources of a system that people at different risk. And so recognizing that the adequacy of messaging and public health messaging and awareness in terms of true risk of disease, I think, is really important. And so I think those are maybe some of the key learnings that we can take from prior pandemics.
Great. Thank you, Amita. I think that those are some critical points that you have mentioned, given the wide context, as Venkat was also addressing the complexities, the diversity that we have. So leveraging on lessons learned from addressing these previous issues. I think from what both of you said in terms of having, collaborative approach, in terms of having the right communication and having the right engagement with the communities. I would like to move to Vivek from these perspectives. Vivek, from your extensive experience working with international agencies and with UNICEF now, international agencies play a big role in pandemics like these, where the best practices are set, the collaborative ecosystem is established, things are facilitated for the policymakers, the scientists, and the implementers on the ground to have a cohesive effort that can, help regional, national, and a global sort of answer to these different problems. So, from your perspective, what role do you see for international agencies in this current COVID-19 pandemic era, in addressing and moving forward?
Thank you, Nikhil. I think that's a good question, especially after the interventions from Venkat and Amita. And let me then speak around 4 words which I've picked up from what they said and what international agencies are doing. And it is about science. So how the international agencies, especially led by the UN, is simplifying the constantly evolving science around the new virus, how they are supporting the states, and the very important issue of stigma and discrimination. Because, when there is an unknown, there is fear of the unknown. And when there is fear of the unknown, it's very easy to attribute it to the other hypothetical other, and it could be anybody. And that's where people also sometimes take advantage of that situation. And after that is the issue of solidarity globally, solidarity within nations. So first of all, to begin with, what international agencies are doing mostly is around the technical guidance and strategic advice to the states. And as you said, taking experiences from this evolving understanding of the virus from one country to another, because they are in different stages. And then also trying to help the countries to adapt these guidelines and then implement these guidelines. That is where most of the work of international agencies is. Second most important part is focusing on the vulnerable communities and also the vulnerable and fragile health systems across the globe. So for example, specifically, there's a Central Emergency Response Fund, which was released about $15 million even before the pandemic was announced. So just after the public health emergency for international concern was announced, these funds were released for the most fragile health systems across the globe. So focusing on the most vulnerable, and then also ensuring equitable access to the upcoming diagnostics and the vaccines and the therapeutics that will come, because that's also a very important issue. And for that, UN then initiated something that we call Access to COVID Tools Accelerator, which is accelerating the development and rollout of these tools, but most importantly, ensuring equitable access to these tools so that the most fragile nations also have the same sort of access than the other countries which may be privileged. So these are the core areas. And then finally, about stigma and discrimination and how that should be reduced globally and within countries, and we should have a whole of society solidarity response. So the UN Secretary General, he appealed personally to the heads of religious institutions globally that for whole of society approach, and especially for solidarity, we need all religious leaders, we need political leaders, we need scientists, we need civil society organizations. So these are the four core areas where international agencies are working. And finally, there was also a joint, what we are calling the Global Humanitarian Response Plan, which is sort of an appeal, which includes the appeal for about $6.7 billion to individual entities, to philanthropies, to anybody who wants to donate, including to the civil society organizations who are working with the communities, some of the most vulnerable communities across the globe with foots on the ground. So these are the four core areas where the international agencies, collectively UN and the others, are trying to support the pandemic response.
Thank you so much, Vivek, for that. I really liked the word solidarity that you have pointed out. In these tough times, I guess, you know, while the scientists and the public health specialists are doing what they're best at, I think it's critical that we work together on various aspects of it, not only from a perspective of addressing this in terms of the solutions and management, but in terms of the system for each other. I think that I would like to go to again, where you addressed the various aspects of you know, global response to this pandemic and the parameters that need to be outlined to make that more effective and efficient. There yet remains, you know, issues that are specific to the region or the country that need to be taken along with as we are addressing this difficult problem and the times that we are in. So Venkat, from your extensive experience in working with comorbidities and diseases like diabetes, as you know, India has a huge burden of diabetes, of other comorbidities like TB and various other infectious and non-infectious diseases. And given this additional burden that COVID-19 has now presented, what, in your perspective, would be key areas to look into in terms of co-management of these different diseases as we move forward in the COVID-19 era?
Thank you, Nikhil. And before I answer that, let me make one broader comment about response in general. There is a tendency, a natural tendency, to see a lockout or a place an order as a solution. It is not. What it is, all it provides you is a raft and time to come up with action and to put things in place. So that cannot work on its own unless it's followed up with active testing, very careful testing of cases, and testing of contact. Contact tracing is critical to bring things under control. And then beyond it, to ensure that you're testing regularly so that you're preventing relapses, etc. And this is again a place where Kerala has done extremely well, as have countries like New Zealand have done extremely well, and you're seeing positive results there. Now, coming to your specific question, very clearly what this pandemic has pointed out is that people with comorbidities seem to be at high risk. Clearly, the case of diabetes is common for both the US and India. You know, and in India, you have situations like people with TB. In the US, we have situations like high prevalence of opioid and substance abuse in certain communities. So the important thing for me is to understand that these diseases don't exist in silos. I think if there is one lesson, that is the lesson. The second important lesson, when you really think deeply about it, the organization and management of these diseases have many common features. I mean, If you talk of TB, you're talking of having people to comply with drugs, supply of drugs and compliance with drugs for 9 or 10 months, which is what the DOTS program does. And the same thing is important when it comes to diabetes. It's about ensuring essential medications and ensuring that people are able to maintain it. And I think you can draw these kind of analogies, but I think what this points out are three important things. Firstly, stop looking at diseases as silos. The same person can develop other diseases, so you need a broader appreciation of the coexistence of diseases, coexistence of TB and diabetes, of COVID and diabetes, etc. That is essential to understand. So hyper-specialization tends to take away that important fact. So this is where the role of strong primary healthcare and organized systems become extremely important. So access to care is a second important thing. And the third thing we are understanding, at least from our research in diabetes, is just like a prepared mind, helps you identify the greatest opportunities, so too a prepared system is the best one for both delivering high quality care during peacetime and also provides the ability to deal with a pandemic during a crisis. And that such an organized system means well-trained workforce at grassroots level, good, strong primary care, which is well-funded, which is a high level of respect, good public health infrastructure, extremely important, access to essential medications, and very importantly, methods to ensure compliance with interventions, whether it's preventive interventions or therapeutic interventions for diabetes, TB, etc. All of those are extremely important, and all of these needs to come in with some sort of a quality of healthcare metrics and a quality of public healthcare metrics. I think bringing all that together, so essentially what I'm arguing for is strengthening of primary and public healthcare systems, and secondly, expanding the notion of medicine to actually mean social medicine. I think ultimately the people who are most vulnerable are those who are, economically and socially disadvantaged. So that appreciation, the role of the physician goes beyond just, providing a pill or a prescription, but actually goes into the laboratory of how these diseases exist in communities. I think that's where I would end. And I think that's common for a pandemic, and it's common during post-pandemic times to deal with diseases like diabetes, hypertension, TB, etc. There are many common features, and that's what we need to shift our thinking towards.
Right. No, thank you so much for that, Venkat. I think that's very, very critical, given some of the other things that we discussed, previously from all of you. And I think this last point on looking at vulnerable communities is something that is highly critical, also to what Vivek mentioned about stigma, and to the things that you mentioned right now about the various public health metrics like access, care, the quality. I think on that note, Amita, I would like to get some of your thoughts. We have a variety of groups in terms of, who are vulnerable in this current situation, whether it's the migrant laborers, whether it's the gender, whether people by age. And this is something that has been a significant area where in the HIV space as well, a lot of work has been done. Again, building on the discussions we just had and from your experience, would very much like to hear, what would be the impact on these vulnerable groups from this COVID-19 pandemic, and what, according to you, would be the best path moving forward in terms of managing that impact that helps these vulnerable, socially and economically vulnerable groups and people.
Yeah, thank you, Nikhil. Maybe I'll take your question in two parts. First, starting with, the impact that this has on socially and economically vulnerable communities. I think first, when we think about the severity of disease, what are the risk factors for severe disease, being kind of, as Venkat touched upon, with diabetes and structural lung disease and heart disease, high blood pressure. A lot of these are more prevalent in low-income, low SES communities. And so if you take, for example, lung disease, that we see a lot of structural lung disease, COPD, asthma, based on occupational risks. So those who are farmers, for example, have more risk of, crop dust, or factory laborers with chemical. And so, these are often more common in lower income, lower SCS groups. Age is another large vulnerability where we see the upper extreme of age being most susceptible to severe disease. Gender also plays a role. If we think about lung disease again, and for women, for example, who historically were maybe subject to more indoor air pollution. And so, gender, age, socioeconomics very much play a key role in severity of disease. Second is, as we think about the indirect health impacts, so, disruption of basic health services. So, whether that's mental health services, whether it's, health services for chronic diseases such as, heart disease, people coming in with stroke who now have fear or are unable to access health systems. And that's compounded on their, from the baseline having barriers to access to care. And so I think that this is another key challenge that's posed by this pandemic. When we think about, if you look at a lot of the National Health Mission data, we're already seeing reductions in vaccination rates among children, decreased access to mental health services, HIV screening has gone down. And so these are some of the indirect impacts of this pandemic on vulnerable communities. And then obviously the economic impact. I'm not an economics expert by any means, but just thinking about what that means in terms of food insecurity for these vulnerable populations. And then the psychosocial impact. We're seeing, increasing numbers of calls to domestic violence helplines, to child sexual violence has gone up if we, look at the helpline numbers. And then obviously, the other mental health impact social distancing has, or physical distancing has. And, that's particularly, severe for those who are of lower socioeconomic status, who may not be able to access many of the technologies that at least those of us who are more privileged have to continue to maintain contact with some of our social support structures. And then to add to that, like when we think of a lot of religious venues where people, could traditionally go to, are not able to go to for support, is adding to that impact of this pandemic. So then shifting a little bit to, just thinking about management, we really need to think about, equal access to public health messaging. What are the ramifications of lack of technology access, and clarity of messaging across different groups. Equity and prevention, so recognizing that social distancing is a privilege. It's not always possible in crowded settings, for example, in urban settlements, is really important to note. And from a work standpoint also, that work within, we talk about, working from home as being a privilege, but in addition, when people start returning back to the workforce, that control over social distancing and taking, precautions of wearing your mask, and that control is often not in the hands of the laborer, but actually the manager. And so, thinking about the power structures there and how that may also be at hand. And then obviously equal access to hand washing, when safe hand washing and sanitization may not be equally accessed across, the most vulnerable in society. Equal access to therapeutics, to vaccinations, equal access to healthcare. I think right now in terms of therapeutics, a lot of the trials. And so how are we going to ensure adequacy, that people across all levels of society have access to emerging therapies? And not that we want them to be, as historically as we learned from other pandemics, guinea pigs of these trials, but also recognizing that they have equal access to these trials, I think is really important, because at least early in the epidemic, this is the way of how you can access these emerging therapies. And then obviously thinking longer term about ensuring that these therapies actually make it to these communities. So I think those are some of the key aspects that we need to think about in terms of management and impact on the most vulnerable communities.
Great. Thank you, Amita. I think these are useful parameters that you and Venkat have laid out in terms of certain specifics, whether it's from a research perspective or from taking that research to the people to whom it matters and creating that ecosystem and environment for them to benefit from it. With these specifics laid out in terms of the context of disease management, in terms of context of looking at the vulnerable populations and enabling different areas for them to benefit from the work that is happening to address this pandemic. Vivek, I would like to understand from you how are the international agencies complementing the various efforts that are happening locally towards some of the areas that Venkat and Amita outlined, whether it's access, creating new technologies, or creating new tools and systems that enable for access of these technologies and solutions. So from an international agency perspective, how are you working in tandem with the policymakers and agencies in various countries and from India as well in addressing this pandemic?
Thanks, Nikhil, and very valid point. So I'll just pick from the three things which are continuing in the arguments of the three panelists. That at a global level, we were looking at the international agencies supporting the technical assistance on the science, focusing on vulnerable health systems, and then ensuring equitable access to all these tools at a global level. Now, when we come to the country level, I think what Amita said is very important, and I'll come to that as how international agencies are supporting, and also what Venkat said, that this pandemic has only exposed and exacerbated the existing fault lines, the existing vulnerabilities and the inequity in terms of gender, in terms of poverty, in terms of hunger, people who are not having these. So at the national level now, how these international agencies led by the UN are supporting the governments, there are basically two pillars. One is on the COVID response itself with regards to the disease control and all the strategies. And the second pillar is exactly this, that if you look at some of the emerging modeling data and some of the anecdotal evidences emerging, and also from the Western African Ebola outbreak experience that we have, that more people died because of measles after Ebola than Ebola itself. So there are two pillars of support at the national level, and this is not just in India, across board. First is the disease response itself, and second is continuity of essential life-saving services, especially for the vulnerable population groups. So specifically what the international agencies are doing for disease response, it is strengthening of the surveillance. So if you see today, for example, taking India's situation, it's almost like a continent, 37 states and union territories with all the data that we need for customizing our response, and strengthening of surveillance, ensuring that there is a campaign, the risk communication and community engagement campaign. So what the international agencies are trying to do is they're trying to ensure that the government is supported for a whole of society approach, where the communities are also engaged and empowered to take care of themselves and the others around them. And that is very important because, unless there is solidarity at the community level, it will be very difficult for the epidemic response to be effective. So these are areas: risk communication, the surveillance, and then also operational research. Operational research, for example, if at all, hypothetically, when we say that we have modeled and these many extra deaths can happen, so are they happening and where are they happening? Who are the ones who are getting affected? So that, there can be some response. So that is where the international agencies are engaging. Another important area is, for example, within the UN, the UNICEF is guided by a policy document. We call it the core commitments for children in humanitarian action. And when we say core commitments for children in humanitarian action, because children need families, especially the mothers, so it virtually engages the entire community. And this is a policy document around which we engage with the governments, and also we rally the stakeholders, including the civil society organizations, to ensure that certain rights of children and their families are protected. And these rights are very basic rights, as Amita also pointed out, that if hand washing is the most important intervention, do we have the ensurety that communities have access to water to be able to wash their hands? So what is happening to the health for everyone? So health rights, education rights, so education is getting hampered. How are we engaging children in the homes when they are in the lockdown? then access to water, wash services, as I said, and also child protection for that matter, as Amita said, that childline data that she was mentioning. Another area is psychosocial support. This is the biggest, people are saying this is the biggest psychosocial experiment world is seeing in a century, that a pandemic. So one of the biggest areas of intervention is also where the UN agencies, along with the other stakeholders, National Institutes of Excellence, especially like the NIMHANS in Bangalore, National Institute of Mental Health and Neurosciences. So we are trying to empower communities and especially health workers for psychosocial support to them. So that's another area. And most of all, in trying to see that we empower these civil societies to keep the government and even the UN challenged for the accountability that we should have for the population we are serving. So that is where we are engaging the administration in all the states. We are engaging the businesses to make sure that they pledge their donations to the right cause. We are engaging the civil society to empower them to make us accountable, the governments and the UN system, for the humanitarian response. And I must also compliment the government, because it takes really a lot of hard work, and as Venkat said, it takes a lot of fidelity with science to be able to have an effective response and focus on the most vulnerable. And some of the states and also nationally, it takes some tough decisions to be able to do it. And this is so, as economists also say, so this is not economic slowdown because of demand. This is a supply side issue. Like, if there is no health, what's the issue? I mean, what's the point of having an economic? So that is why the first and the foremost has to be taking care of this health challenge that has come to us globally. And that is why some tough decisions also need to be taken by the governments, and we really compliment some of the governments that are taking them.
Great. Thank you, Vivek. Thank you. Just keeping in mind the time that we have left, we have around 15 minutes remaining. And before we open the platform for some questions that may be coming from the audience, I just wanted to get some closing remarks. So from an overall global perspective to the specific issues in the space of public health that this COVID-19 pandemic, as Vivek mentioned out, has exposed, the fault lines and the various aspects that probably were getting covered, in the day-to-day life. I think I would love to understand. We have a set of a variety of parameters that we outlined here, but how would we prioritize, these? So from that context, Venkat, in your opinion, what would be the 3 critical areas that you think we should be focusing on as we move forward in addressing, this emergency response to the COVID-19 pandemic, in terms of strengthening and creating new systems? The 3 areas that you think would be most significant in terms of their impact in addressing this problem?
Yeah, I think a very good question. So my 3 priorities here would be, firstly, preparedness and strong public health surveillance systems, and modern dynamic surveillance systems that are broader and more specific than currently available ones. We need data at very local and granular levels. I mean, like, for example, in the US, we need data at the level of counties, and in the case of India, districts and sub-districts. And that country has done well by mapping data at district levels. I think so that is going to be extremely important. And we also need to think of surveillance beyond just health parameters. We are probably going to require, indicators of economic hardship, indicators of comorbidities, indicators of other factors such as people's mobility, etc. So surveillance is one area that needs to be modernized. And this is where we can learn a lot from the Scandinavian countries. They have excellent population-based systems that connect public health data and clinical data and community data in a very positive way. And that's good. That's number 1. Second, is the role of transdisciplinary science. Connecting all the way from basic sciences to epidemiology to marketing is going to be important. Just to use the example of a vaccine development, yes, the immunologists can find out and tell us that the spike protein is very immunogenic. Sure, they can come up with vaccines that seem to have, immunogenicity, but then we need to know, are those vaccines safe through randomized controlled trials of large numbers, and can those trials be done through global collaboration rapidly? That is important. And then, okay, you have done the trial. Is the vaccine safe to roll out? What are the mechanisms for rolling it out into the community? Are you able to make the vaccine affordable? I mean, countries like India, you require the vaccine to be affordable. So this whole pipeline of research needs to be viewed as transdisciplinary science and not be happening in a disorganized silo. It's easy for different labs to come up with great inventions, but if you have to take those inventions to health benefit and to the market and to population health, it requires a very coordinated system of science. So that would be my number 2, transdisciplinary science. And thirdly, I think this pandemic points out to all of us that what is really important is strong primary healthcare systems and strong public healthcare systems where you have well-trained workforce. During a pandemic, these are the people that are going to go and do contact tracing and surveillance data collection. And during non-pandemic times, these are the people that are going to coordinate delivery of healthcare for women and children, for TB, for diabetes, etc., under guidance. So that workforce is important. The role of technology becomes increasingly important. I think more and more, technology-based health prevention, healthcare interventions will happen. More of telemedicine will likely happen and give us the possibility to reach out to more remote areas. So I think this pandemic, when it's over, is going to give us tremendous opportunities to shape a healthier future for our populations and for our people in all countries. And I'd like to offer one fourth thing, that what the pandemic has shown is that regardless of how much local strengths you might have and scientific technology strengths you might have, it is vital to have a highly reputable central agency such as the Centers for Disease Control and Prevention in the US. I think we are missing the role of a CDC, of a real CDC, from what we know from previous times. That is essential. You can't prevent cross-trace state transmission, etc., without a strongly driven, science-based, evidence-driven Centers for Disease Control or a similar kinds of agencies in countries like India. I think all these would be my priorities. Strengthen surveillance, strengthen transdisciplinary science, strengthen primary care and public health infrastructure, and finally, empower strong independent agencies like the CDC.
Great. These are like really great points, Venkat. And I think, like Vivek mentioned, with addressing of these major points that you have highlighted, the exposure that we have had in our fault lines would be significantly addressed, not just for addressing this pandemic, but moving forward as well. And taking a cue from what you said, in terms of strengthening the science, strengthening the systems, having the agencies, having the technology, but most critically, all that is taken to the people for whom it matters, that last mile delivery. And that's where, Amita, I would like to ask you, what according to you would be some critical models of management in addressing that last mile delivery, especially in an Indian context where we have a lot of diversity and complexity in terms of, region, size, the rural and urban divide, and the limited resources. So what, according to you, would be maybe 2 or 3 critical models or areas that one can address in managing these issues while we make that last mile delivery as effective as possible?
Yeah, thanks, Nikhil. I think in answering that question, the Ministry of Health and Family Welfare has put out some terrific protocols and terrific procedures and guidances regarding how best to do that. I think part of that largely builds on this tremendous workforce that India has that's trainable, that is, deployable, and that you can really ensure kind of a continuity of message because this infrastructure exists. You think about the Anganwadi workers, you think about the ASHA workers, you think about the government social workers that are really a big presence of multiple different vulnerable communities. And if you can ensure the fidelity of training from top all the way to out in the community, I think that's really important and putting emphasis on that. But just, looking at some of these procedures that the Ministry of Health has put forward, for example, for urban settlements, for slum communities, like how do you socially distance? There's some really neat things that are, mentioned in these. So for example, talking about heightened surveillance using some of these workers that I mentioned earlier, having them actually do symptom screening, having them do pulse ox monitoring and temperature monitoring, having them be the avenues of addressing stigma, of ensuring public health messaging, I think it's really important, and it's very much feasible. I think there's important models in terms of distancing that are also outlined and how you can do that in closed settings. Like they've thought about everything from just how do you in a small slum setting, how do you sleep distanced such that your heads aren't together to reduce transmission. And I think there's really small nuances that are mentioned that I think are worth consulting. Second, regarding the rural management, how do you manage this in rural communities? There's a lot of great literature out there from prior epidemic management. So thinking about adequacy of water sanitation. There's some really neat rural NGOs that are working out there, where women's entrepreneurship groups. Chetna Sinha, founder of Mandeshi Foundation, put out a nice piece about how women's NGOs who previously used to do clothing manufacturing basically are now making masks for the communities. And I think that's, it's these small grassroots entrepreneurial activities that we can really build on as we think about the epidemic in rural settings. Shifting culture around hand washing and integrating soap into hand washing across, various, post defecation, post sneezing, post coughing, all of that culture needs to also be changed. And then lastly, I think, thinking about the emotional impact and the psychosocial impact. Vivek, I think, touched very nicely on the impact on the health workers. I think that's really important also among the communities. And, reading some of Vikram Patel's work from Goa, like how do you use community health workers to actually provide the psychosocial support in the community such that they don't need to come to the health, to the actual clinics or to the system itself, and promoting distancing in that manner, I think, is really important. And then, lastly, touching on Venkat's comment about using this as an opportunity for infrastructure development, I think, Soumya Swaminathan very much talks about this, and I think it really is an opportunity to further strengthen our existing health structures, both in India as well as here. And so I think those are my closing thoughts.
Thank you so much, Amita. In the interest of time, I guess we will take a question or two from the audience, but before we get to that, very quick perspective request from you to the pointers and very critical and important and very impactful pointers that both Venkat and Amita mentioned moving forward. What role do you feel the international agencies will play in enabling some of these pointers? What kind of health governance and policy perspective will the international agencies provide that will enable in formulation and implementation of some of the critical pointers that were outlaid by both of them, which will not only help in addressing the current situation that the COVID-19 pandemic has presented us, but the post-COVID-19 era, as we hope to see, and any future pandemics that may hit us would be addressed through those changes and approaches. So,
As you said, yes. So 3 things I would focus on. First of all, the point already made that we need investment in health and especially health systems, primary healthcare. As Amita said, primary healthcare means today it's the primary healthcare workers which are ensuring continuity of immunization in different scenarios in India. Today it's the primary healthcare workers, even in dense population urban settings, for example, Dharavi in Mumbai, that have helped the Principal Scientific Advisor's Office in India to come up with guidelines of COVID containment in Dharavi like dense slums. So investment in primary healthcare, because health security is a misnomer if there is no health system resilience. That is why this should be the first priority collectively of states and the UN agencies, and that is where the agencies would be focusing. Second point is, we are still not realizing that the international health regulations which came into effect in 2007, the origin of which was into international sanitary conventions in the 19th century, as it gradually evolved historically, there were predetermined measures to check diseases at own borders. What International Health Regulation 2005 brought about was that there was a need of containing wherever it starts and the global solidarity, everybody coming together. So that's the second most important area, that now countries should start rethinking about global health security and international health regulation core capacity compliance. Because if you look at, and I do not want to point to the specific papers, the ranking of global health security by country and how they are performing during the pandemic, there is no correlation in many of these countries. So this is the second most important area, that health security as it understands, we need to relook at it. And the final point is that we know that pandemic has literally put an halt on our sustainable development goals. And when we began this century, it was on such a high note that this is going to be the decade of action. We are calling it the decade of action. So I think, as Venkat very rightly said, this should not dishearten us. This pandemic should only lead us to be more resolute, redouble our efforts in the pursuit for those sustainable development goals that we have set as humanity for ourselves for 2030, and ensuring that these targets for achieving those goals for health of universal health coverage, that is health for all everywhere, and especially focusing on the most marginalized, we should not get disheartened. We should not take our eyes off that goal. And in fact, we should redouble our efforts as humanity, collectively, globally, to ensure that we again fight to be on track to achieve these goals.
Thank you so much, Vivek, on leaving us on that positive note of action and making the most out of this difficult situation we are in. As they say, difficult situations sometimes bring out the best in us, and that's what is happening. And we hope that happens in a more accelerated and effective manner, so that as a humanity and community and individuals, we benefit from everything else that comes out in terms of building these processes and systems through this COVID-19 pandemic. So before we try and close this, we have reached that 1 hour time limit, but we will just take a question or two quickly from the audience, any pressing questions that we may have for our panelists today.
Great, I think we have time for one last question. Someone asked, what is the greatest change the 21st healthcare is going to face once the vaccine is created, other than vaccine distribution in both India and the US?
So, okay, so in terms of accessibility of, once we have, thank you for that question. I think that remains a very critical thought, and like we addressed in various pointers that we discussed today, but any specific quick pointers from each one of you on that point of accessibility of vaccines once we have it?
Yeah, I mean, I think what's the biggest thing? I think we need to be aware that this is not the only pandemic that the 21st century might face. There could be others if we are not careful. So I think using this pandemic beyond, you can come up with bullet shots like a vaccine, etc., but that is only part of the solution. The real solution lies in putting in place preparedness, such as strong infrastructure, and also addressing zoonotic health and One Health in a way that we diminish the possibility of pandemics like this. I think that is going to be important as we go forward.
Thank you, Venkat. Amita?
Yeah, I think in addition to vaccine access being, a big question, is second to access is what is uptake and what are the barriers to uptake and what are the perceptions around that vaccine and beliefs around that vaccine. I think are really going to be interesting and very important for us to understand as we get this vaccine.
Any thoughts from you?
I mean, I would also say that, more than the medical vaccine, we need a vaccine where we focus on the determinants, which are social, economical, commercial, and environmental. And as Venkat said, One Health. I mean, microbes are also evolving and we need to be ahead of them. And unless we are ahead of them, it needs to have a different vaccine where we are focusing on all the determinants of health and clearly understanding what they are.
Great. Thank you so much. I think between the points that we discussed in terms of health system strengthening, and providing access and systems for these vulnerable groups, for the socially economically challenged groups, and from this broader context of what you mentioned about One Health. I think these are different parameters needed to take from whatever is developed to people who need it, and also for addressing these pandemics from what we have right now to a global perspective moving forward. So with that, and in the interest of time, thank you so much to all of you for sharing your thoughts, and more importantly, for the critical contributions that all of you are making in this decade of action that we are outlining this. And before we close, I would so sincere thanks again, and I would like to bring on Katie here, who's been instrumental in bringing these webinar series together, for providing a closing note on her behalf, please. Please, Katie.
Thank you so much, Nikhil. So as the Executive Director of International Advancement and Constituent Engagement at Emory, I just wanted to really share my sincere thanks to Venkat and Amita and Vivek for your time and for your incredibly important and timely insights on this really critical topic. I also wanted to just do another quick thank you to Neha, our chapter leader in Delhi. This was really the brainchild of Neha, and I just love the idea of bringing together our work in India and our work at Emory in Atlanta, and just how we're able to cross borders in this way. And I'm thrilled that we have been able to launch the first in what is now a series of 6 of these topics that we'll have as part of our series Virus Without Borders. If you are participating from India, I wanted to remind everybody to please, if you're not already part of the Facebook group or either of the WeChat groups that are part of our India networks, please reach out to me or to Neha and we can get you connected on those. Also, please sign up for our Emory's Digital Engagement Hub, where you can find this recorded presentation as well as other presentations, and even fun activities such as happy hours as part of our alumni community, and that can be found again on Emory's Digital Engagement Hub. And also, please look for us on momentum.emory.edu. That is the site that has all of the different funds for COVID-19 at Emory that support frontline workers, our students, our faculty, our staff, our hardship fund, all in this time of Corona. If you'd like more information about where funds are being allocated to support our Emory community, and there are ways to also contribute personally if you're interested and able to make contributions to support our community in this time of need. Please mark your calendars for Thursday, May 28th, and join us for the next in Virus Without Borders featuring Professor Jag Sheth. He will be talking about business transformation in the time of COVID, achieving the next normal. That's the end of our presentation today. Thank you for all who attended, and see you at the next presentation, and stay well.
Thank you very much.